excellent presentation.
Thank you.
Now, I just want to touch on your presentation and the previous speaker, of course, continuous glucose monitoring. Now, do you think that what you have presented, okay, make us think again about bariatric surgery as a cure for obesity? And I think I need to hear both of you. The other three.
It's a question for me about bariatric surgery, not about intermittent fasting.
Sorry?
Not about intermittent fasting?
It is intermittent fasting.
Okay.
You could replace the bariatric.
Well, as you can see from the presentation I did, there is not much of evidence for long-term studies. So when we have more longer studies, we can say how much benefit. But as you can also see, from the level of reduction of the weight is not that much significant, and it's for a short period. So I don't think we can compete with this with bariatric surgery. But, you know, as you heard and you know, there are many medications already there that probably also can help into bridging the gap between this and maybe with bariatric surgery.
I would like to listen to the other speaker, their view on bariatric surgery and intermittent fasting, or fasting, you know, and metabolic treatment of obesity. Please.
Okay, I can give it a shot. So, weight loss is clearly an unmet need in society, but in our people with diabetes specifically. So, I think if we can find a way of easily losing weight, which is cost effective and safe, then that's really wonderful, because this is a problem across all of society. And clearly intermittent fasting is going to be a lot cheaper and more accessible than bariatric surgery, which can only occur in very specialist centres. Now, there will be some new kind of tools which are potentially less invasive than bariatric surgery, using, you know, endoscopic techniques, for example. But still, that needs a specialist centre in order to do that. So, as a diabetologist, we have lifestyle, which includes dietary management in all of its forms, as well as exercise and different components like not smoking, for example. And that is the kind of backbone of everything that we should be doing. And then we've got drugs, and clearly there's some wonderful new drugs which are helping us to achieve our weight goals, in addition to addressing glucose lowering and cardiometabolic complications more generally, including non-alcoholic fatty liver disease. So GLP-1 receptor agonist, SGLT2 drugs are good. And then we've got the new, on the horizon, GIP, GLP-1 receptor agonists, which hopefully will be with us in the very near future. So that has been transformative in the way that diabetologists, who by definition prescribe drugs as opposed to perform surgery, try and help our patients and people more generally to lose weight. And then we have surgery, and again, very few of my patients have surgery, so I'm not sure where the question is coming from exactly, but that's my take on all of this. I think intermittent fasting is good, but, you know, can you do it for life? I don't know.
If I may, I would like to tell also my point of view. Now, there was a nice work published in JAMA a couple of years ago, where they find, that is related to data in the US, that the BMI in patients that perform bariatric surgery is 45, the average BMI. After 2 years, the BMI is 35. So the decline that appeared earlier in the first year at 29, after 2.5 years, roughly is 35. So the results is not so dramatic, because if you get from 45 to 35, it's definitely an improvement, but then it tends to increase again after 5 years. So I think we should keep in mind that this is for the American population, and so maybe that is not the same for other populations, but this has to be kept in mind. So the bariatric surgery is not so successful as seems to be in terms of achieving a real decline in body weight within, I would say, overweight at least.
Thank you, Prof. Bozzali, and thank you, Prof. Glenn. You want to add anything, Prof?
No, I wanted to ask Dr. Pozzilli. Dr. Pozzilli, how are you today?
Very well. Nice to hear from you today. It was a pleasure. I would like to be with you today in Bahrain, but I'm in Rome, and that's fine. At least we interact.
Right, next time. I have a question for you about the interesting topic that you presented about GAD positive, you know, not LADA, you're calling them differently, right? Now, the question is, these people are positive with GAD65, as you mentioned, and then later on you mentioned that you treat them with metformin, and then you put them again with the group of the vascular complication, you know, like the algorithm. Do you think they will behave similar to type 2, these people, or less of vascular complication?
Well, that is a very interesting question. Unfortunately, we do not have trials that show how do they follow in terms of vascular complications. Nevertheless, if you look at those patients, by all means, they behave like type 2s, not like type 1s, definitely. So in terms of potential risk, I would say that the risk is similar to patients with type 2 as far as behavior, but as far as the process, probably differs because they do not possess the same risk factors associated with type 2 diabetes. This is an interesting point, and only long-term studies may help us to see whether this population behave differently.
Thank you very much.